Welcome to Cardio Radio, a podcast of the Ohio Cardiovascular and Diabetes Health Collaborative, also known as Cardio. This is Dr. Michael Konstan from the Case Western Reserve University School of Medicine, and I serve as the principal investigator for Cardio, a statewide network of Ohio's 7 medical schools. Cardio is funded by the Ohio Department of Medicaid and shares best practices to improve cardiovascular health, diabetes outcomes, and to eliminate health disparities in Ohio's Medicaid population. The opinions and recommendations in this podcast are those of the presenters and not those of Cardio and its sponsors, and are not intended to be a substitute for medical advice. I hope you enjoy today's podcast.
Hello, I am Dr. Colin Crowe, Assistant Professor of Family and Community Medicine at Case Western Reserve University, a family physician at Metro Health, and podcast lead for Cardio's Team Best Practices. On today's special edition podcast, I am joined here in the studio by Dr. Michael Konstan and Dr. Shari Bolen. Dr. Konstan is Professor of Pediatrics and of Population and Quantitative Health Sciences at Case Western Reserve University and serves as the Director of Community Health Programs at the School of Medicine. Dr. Bolen is Professor of Medicine at Case Western Reserve University, a general internist, and serves as the Director of the Population Health Research Institute at the Metro Health System. They have served as Principal Investigator and Co-Principal Investigator for the Ohio Cardiovascular and Diabetes Health Collaborative, better known as Cardio. Welcome, Mike and Shari, to today's special edition podcast. I am so glad to have you both here in the studio.
We are delighted to be here.
Yes, this is quite a milestone moment, so glad to be here.
Great. Well, today we are going to celebrate the work and success of Cardio over the last 9 years. And with your help, we're going to reflect back on how it all started, the work to improve the health outcomes and address disparities for all Ohioans, and we're going to share your stories and lessons learned with our listeners.
Fantastic.
So to get started, can you take me back 9 years ago to the initial conversations that were happening? Where did this idea for Cardio come from? How did you get from this seed of an idea to a massive functional network of experts across the state?
There was really a visionary at the Ohio Department of Medicaid that developed the idea of a statewide collaborative. And then funded by the Medicaid Technical Assistance and Policy Program, also called MedTAP, through a mix of state and federal dollars and through funding from Ohio's 7 medical schools, the statewide cardiovascular health collaborative is a mechanism to improve the quality of care for Medicaid enrollees. It had an initial focus on hypertension and then later expanded to diabetes, other cardiovascular risk factors, and also focused on addressing the non-medical determinants of health. Mike, what else would you add?
Well, I'd like to add that this collaborative was unique in several ways. First, it was a statewide approach, and it also united Ohio's 7 schools of medicine to serve as the backbone for the collaborative. It also formed partnerships with networks of primary care providers, Medicaid managed care programs, and the Ohio Department of Medicaid.
Okay, so the idea originates in the Ohio Department of Medicaid, and then how was the collaborative formed?
Well, it's following a competitive application process. Case Western Reserve University was selected to serve as the lead institution in partnership with the other schools of medicine in Ohio. And so that included University of Toledo, the Ohio State University, Ohio University, University of Cincinnati, Northeast Ohio Medical University, and Wright State University.
Why were these academic medical schools chosen as this backbone infrastructure?
Well, the academic medical schools were chosen as the backbone for several reasons. First, they could help establish the evidence-based strategies to be used and promoted for cardiovascular health improvement. Second, they're often seen as interprofessional conveners for the region. And third, they typically have large affiliated primary care networks. And those networks could really be taken as test sites to disseminate best practices.
Okay, so leverage that proximity to the evidence-based research, the broad interprofessional approach that already exists at academic medical centers, and then using that primary care network belonging to the academic center to spread it throughout the region. Okay, what happened next?
Ohio's medical schools' response to our invitation to partner was overwhelmingly positive. Blood pressure control is an important metric to the schools of medicine and their networks of primary care clinics. So I think they also saw the value of this unique collaborative to work together, something that doesn't easily happen in such a competitive academic and financial environment. So initially, we focused on bringing together the schools of medicine to build a strong foundation and backbone for the collaborative before quickly moving forward. I can't underscore the importance of the work done in the early days of this project to build our team. We recruited Ohio's top subject matter experts. There were executive leaders, strategic advisors, data scientists, and marketing and communications talent to design and bring to life this exciting vision. The team was then and continues to be, after all these years, top-notch. You're only as good as your people, and we've had the best of the best.
Okay. Well, what about other partners in the collaborative beyond just the medical schools?
Well, we began our collaborative by bringing together the medical schools and a group of key partners to assist us in developing our vision, mission, and activities. Some of the key partners were Ohio Department of Medicaid, the American Heart Association, our primary care clinicians, and the Ohio Association of Community Health Centers, and those are just a few of the ones that participated in providing their insight and feedback to our work.
Can I ask who came up with the name Cardio? It's genius.
Oh, yeah, we do love the name. We did a brainstorming process with our PIs, our team leads, and our communications team. And our executive director of our community health programs at Case Western Reserve suggested that the name that was ultimately chosen by our group.
Awesome. Well, tell me a little bit more about what it was like to work with ODM on something this large.
Well, it was quite the undertaking. We knew that Ohio Department of Medicaid's goals for Ohioans, though, would align with our own at the Colleges of Medicine. We really focus on sharing evidence-based best practices, expanding primary care team capacity, and addressing health disparities. And then having the Medicaid managed care plans at the table has really enhanced communication around what insurance barriers could be addressed to improve health outcomes. So, for example, the Medicaid managed care plans came together to remove some of the prior authorization restrictions on continuous glucose monitors. So we were able to prescribe continuous glucose monitors more easily to patients, and then they were able to obtain them more easily. Another example is the change from 30-day medication prescriptions to 90-day medication prescriptions. And we know with just a simple change like that, it can really improve medication adherence, which leads to improved health outcomes for hypertension and diabetes.
By working together to expand primary care teams' capacity to prevent, diagnose, and manage cardiovascular health and diabetes in Ohio's Medicaid population, and to identify and address disparities, well, then the Ohio Department of Medicaid wins and Ohio wins.
Yeah. Well, I'd like to talk a little bit about Cardi-OH's best practice resources. So I think a unique aspect of this project is the incredible online resource library of these best practice resources. I know that for me, the opportunity to collaborate with team members from medical schools across the state on writing groups has been really rewarding. When I joined Cardio in 2020, I jumped in to lead the creation of Capsules and Currents, two of our materials that are intentionally brief for busy primary care clinicians. They're concise, they're focused, they've been so helpful to me in my practice. They summarize the new guidelines, introducing relevant tools for communication, new and late-breaking advances for primary care clinicians caring for patients with cardiovascular disease and diabetes. Of course, the longer articles are great when there's a need for a deeper dive. Not to leave out our podcasts, what we're doing here today. It's hard to believe how far we've come and how many of these pieces we've created. Shari, can you tell us what the most popular topic areas have been for these cardio resources?
Yeah, I think that's a great question. And there are generally 4 main buckets of topics which are popular. The first is treatment algorithms, such as our diabetes and hypertension medication treatment algorithms is very popular. Or how to switch between glucagon-like peptide 1 agonists due to formulary issues. The second bucket is communication. Things that were popular were motivational interviewing, shared decision-making, and goal setting. The third topic that's popular is lifestyle, such as exercise and diet. One of our most popular pieces is our 1-page dietary approaches to stop hypertension or DASH diet handout that is low literacy that patients love and can use. And then the fourth bucket area is social drivers of health. So things like screening tools for social drivers and how to address specific social drivers like food insecurity are some of the more popular things within that category. Now, Cardi-OH has, as you know, a very extensive online library with lots of best practice resources, hundreds of them. They're really available at no cost at cardio.org and on our web app. So I would encourage all the listeners to go and check them out if they haven't already.
Awesome. So hundreds of documents, tons and tons of hours went into these from experts across the state. How did you, as the leadership team, determine which topics to develop?
Oh, that's a great question. As part of our annual program evaluation, we developed these needs assessment surveys and that we deploy these each year to cardio readers and to collaborative members. And we identify specific needs and gaps for each of the cardio teams to inform the development of the evidence-based best practice events and materials for the following year. Preferences for dissemination were noted, and prioritized topics were covered in articles and in capsules. We found that asking what cardio members prefer regarding both topics and dissemination modalities led to increased engagement with the collaborative.
Sure. So the best practice is give the people what they want. Keep the content practical, concise, and clinically relevant.
Exactly.
Hey, Mike, since we're here discussing our best practice resources and the beginning of cardio, it would be really fantastic to have Dr. Jackson Wright join us, who helped us with all of those things.
Oh, you're right, Shari. That would be great.
That is a great idea. So we're going to try to get Dr. Wright on here via Zoom. While we get him connected, I'll introduce him to our listeners. So for those of you who don't know, we're going to welcome Dr. Jackson Wright Jr., an emeritus professor at Case Western Reserve University and hypertension expert who helped lead both the formation of cardio and the development of cardio's resources. Do we have him through? Hello. Good to see you, Dr. Wright. And thanks for joining us. We're here in the studio for Cardio's special edition final podcast.
Welcome, Jackson. So good to see you, even though it's virtual.
Great to see you, Jackson.
Thank you for the invitation to participate in this podcast of reviewing the work of cardio over the past 9 years.
So, Jackson, if I recall, you were in the process of retiring as cardio was being formed. So what made you decide to participate in this, even with retirement so close?
Essentially, over the quarter century prior to cardio, I was privileged to be the leader in essentially the major trials forming the evidence base for the current guidelines in the management of hypertension, which was the first initiative undertaken by cardio. In the antihypertensive lipid lowering to prevent heart attack, or ALLHAT trial, we identified the agents most effective in preventing the complications of hypertension, including the thiazide-type diuretics. In the African American study of kidney disease and hypertension, the ASK trial, we showed the benefit of treatment to less than 140/90 and the use of ACE inhibitors in slowing the progression of kidney disease, especially in Black patients. In the systolic blood pressure intervention trial, SPRINT, the focus was on systolic blood pressure less than 140/90, was substantially less effective in preventing cardiovascular events and slowing the progression of dementia in patients with hypertension than systolic blood pressure targets of less than 130 and less than 120. In addition, these blood pressure levels can be achieved without race or ethnic disparities and are well tolerated. The SPRINT results have now been confirmed in 7 subsequent clinical outcome trials. Thus, we now know the blood pressure target to achieve to prevent the complications of hypertension and how to safely achieve those targets without race or ethnic disparities. The results of these studies were published and resulted in major changes in both U.S. and international hypertension guidelines, but were not being implemented in clinical practice, especially the blood pressure targets at the start of cardio. So when Shari approached me about cardio, I thought it was an excellent opportunity to work with primary care providers to provide them with the solid evidence-based guideline recommendations to provide the best care for their patients with hypertension.
Yeah, well, that certainly sounds like a lot more fun than retirement. So I'm glad you made that decision. Well, back in the beginning, how did you all decide on what you wanted to do, what you wanted to focus on for best practice resources?
Well, all recommendations to practices were based on solid evidence from national or major society guidelines after review by the panels of experts from the affiliated academic medical centers participating in cardio. Evidence from major clinical trials published between guideline updates were also considered.
And that reminds me, Jackson, that while we had these evidence-based guidelines out there, those resources were really quite long, sometimes over 180 pages, making it really challenging for primary care teams to really keep up with them, read them, and then use them in practice. And I think one thing you did really well is identify those gaps in practice and create brief practical resources for us to use with primary care teams. So for instance, I remember when we started, we had a resource on how primary care teams could explain to patients how to accurately measure their blood pressure at home, which seems like a simple thing, take the blood pressure monitor, go home, measure it. But there's a lot of things that you have to tell a patient around how to sit, what time of day. And not every primary care provider knew all the practical nuances that were actually in the guidelines to explain to patients. So one of the things that we did in one of our resources was to say something as simple as when you're instructing patients, you want to tell them to check their home blood pressure readings 2 times in the morning before they take their blood pressure medications, at least 1 minute apart, and 2 times before bed, at least 1 minute apart, for at least 3 days, so we can average those readings. And there's some other pieces to that, but that's an example of a practical resource that helped sort of consolidate a very long guideline into some very small bite-sized pieces that we could really use with our patients and really help us as primary care clinicians and teams to know what things to highlight in a short period of time. And as a primary care physician myself, I personally learned a lot about hypertension management from you, Dr. Jackson. And really those gaps served as fodder for creating some of our tips and tools and resources.
Yes, obviously something that providers have wanted and needed for years, practical tips that can be used every day in their practices to help their patients.
All right, Jackson, a more lighthearted question this time. What is the most memorable activity for you as part of cardio?
There are many, but I think my most memorable activity was the enthusiasm of the providers in providing appropriate care for their patients. And for me, I also gained a better understanding of the challenges that primary care providers face in meeting the requirements of the new treatment recommendations.
Yeah, I hear you on that one. Well, Jackson, it has been phenomenal to have you with us today. This was really such a treat that you were able to meet us here virtually for this special edition podcast. And great that you were able to reflect on your time and all the effort you made in starting such a massive 9-year statewide effort. So thank you so much for all of your work, and thank you for being here with us today.
Thank you for contacting me and reconnecting with me. And it's been a pleasure seeing all of you again.
Yeah, wonderful to see you, Jackson. So glad you could join us.
Yeah, thanks, Jackson.
What a treat. What a great idea to invite him. He was a founding member of Cardio there when it all started. Great to have him share his recollections and all the effort that went into it in the beginning and throughout. So,
yeah, fantastic.
I'd like to talk a little bit about the Cardio Echo series. So we haven't really talked about Echo yet, but this has been a key pillar of cardio, both for networking with practices across the state, as well as part of our effort to share best practices statewide. So tell us a little bit about Echo and how cardio has used that as one of our pillars.
Well, Project Echo is a virtual training model. It was developed by the University of New Mexico and has been around for over 20 years, although I only heard about it actually when we first started cardio myself. So the Echo model is really this learning community for clinicians. It started with the idea of moving knowledge, not people. And each session feels a little bit like medical rounds. You get a short teaching moment from experts, and then clinicians bring real cases from their own practice. Clinicians gain the skills and confidence to manage complex conditions right where their patients live. And that's why the model has spread around the world. It strengthens care in every community it touches, and you don't have to travel to go learn and hear about what you might want to know from experts. So we've offered Cardio Echo clinics since 2019 on a variety of topics, can't name them all, But a few of them are weight management, primary prevention, innovations in diabetes care, and a new one this past year was really structured around quality improvement.
Okay. So the echo sessions are recorded and they're available on our website on cardio.org. Overall, what would you say you've learned from using the Project Echo model and specifically for teaching quality improvement, QI?
We really learned that practices benefit from monthly coaching calls with quality improvement experts. Our clinical quality improvement coaches were paired up with a practice to provide support for the lead quality improvement coach, and also offered input on clinical questions, practice operations, and workflow. Baseline surveys really helped tailor support, so we knew what they knew to start with. Some practices had strong quality improvement experiences, others needed more foundational training. The best practice here that we learned is really using structured, personalized support. Participating practices don't all start at the same place, so the coaching model has to adapt.
Yeah, and what was really unique about the Cardio Echo series wasn't necessarily the medical complexity of the cases alone, but the complex interplay of the medical and social drivers. And this underscores the value of the multidisciplinary team of experts.
So we started initially with ODM, who had this idea, developed cardio with a small group, but then expanded to the statewide collaborative. And now, what's the reach of Cardi-OH's work?
That is a great question. It's also kind of hard to calculate that, actually, because we're so multifaceted in all the different areas. However, for 2025, as an example, we have over 3,000 contacts in our database and about 3,000 website users each month.
Wow. So if each one of those people took something they learned from a capsule, a current, or one of our long articles back to their practices, they made a change. That's a lot of patients impacted.
Yes, we've really seen outstanding reach across the state from all kinds of practices and all kinds of settings. So urban, rural, suburban, academic, fairly qualified health centers. So really the reach has been great across our state.
In addition, our webinars indicate that over 2/3 of the audience provides direct clinical care, which really underscores the impact of the work into the practices. We've also heard from trainees that they know about and use Cardi-OH's resources in patient care. So it's such a great opportunity for preceptors and academic medical centers to use these available tools to teach the next generation of clinicians.
I know. I use it when I'm precepting residents all the time. Well, do we know if we've had an impact on the health of Ohioans? So are their A1Cs improving, for example? Anything we can point to statewide and say, we did that, Cardi-OH did that?
Well, due to how the funding was set up, we focused on education and dissemination and not implementation. So this really limited our ability to evaluate the impact of the cardio education events themselves. For example, we weren't set up to determine if the cardio educational events and resources themselves, like the Project Echo that we've mentioned, the conferences, webinars, and other newsletters, things like that, whether they actually improve the health of the patients within the participating cardio practices.
However, given that information, we do have from our quality improvement projects, which were closely aligned with Cardi-OH's efforts, that these companion projects use cardio educational resources as they implemented activities within their practice to improve care. So for example, in the diabetes quality improvement project, we found that the percentage of patients with better blood sugar control measured using the hemoglobin A1C greater than 9% improved from 25 to 20% over 2 years.
Okay.
Lower is better in this instance.
Right.
And in our hypertension quality improvement project across the state, which also used cardio educational resources, the percentage of participants with controlled blood pressure increased from 52% to 60%. In this case, higher is better.
Yep.
And as we mentioned before, our Cardio Echo QI series supported practices that were implementing a quality improvement project. So over the years, we provided education and shared learnings that were related to their QI efforts, and these ultimately showed improvements in their cardiovascular measures.
Yeah. Well, let's talk in more detail about exactly what makes cardio so successful. Beyond the polished graphics and that really up-to-date content, you know, in case someone in another state wanted to look at this effort and replicate it, we could share all of the best tips here, unless they were from Michigan, in which case we're not giving them any tips. Fair enough.
Yes. Well, we've learned quite a lot from all of our output and our data collection statewide. One of the clearest best practices is that using multiple communication channels works, and the numbers back that up.
Right. So including those ad campaigns targeting Ohio primary care teams in their work settings or on their mobile devices. So we had ads that would show up on screens in the back office, and that would promote the resources and encouraging the providers and teams to visit the website and register for webinars and things.
And that's right. And we ran monthly ads that targeted 300 primary care offices. It reached over 2,000 healthcare providers. And these ads played over 500,000 times over the fiscal year, so quite a lot. The digital ads reaching providers on their mobile devices generated another 1.2 million impressions. So it's a large amount of passive but repeated exposure to evidence-based contact.
Yeah, I got many of the ads myself on my phone. Yeah.
We also partnered with professional organizations. So the Ohio Academy of Family Physicians sent our content to over 4,000 providers a week. And the Ohio Osteopathic Association reached over 6,000 providers per edition. Those newsletters consistently drove traffic to our website and our best practices resources. And nationally, our campaigns during the American Diabetes Association scientific sessions generated tens of thousands of impressions and hundreds of clicks. For those of you who don't know marketing, that means a lot of people looked at the information that we shared with them. And that's a sign that cardio content is really relevant beyond Ohio.
Yeah. So what I'm hearing here is don't rely on just one communication channel. Meet clinicians where they are, even on their phones sometimes.
Exactly. The more modalities that we use, the broader the audience that we reach. Another best practice is leveraging the 7 medical schools as regional hubs. What makes this powerful is that each school understands the region's unique needs. And so the schools reached a wide range of clinicians that were providing care, and these included nurses, community health workers, dietitians, social workers, pharmacists. So that interprofessional reach is essential when you're trying to improve cardiovascular and diabetes outcomes statewide.
It sounds like that regional model is really one of the biggest strengths of the collaborative.
Yeah, it really is. It ensures that best practices don't just sit on a website. They actually get into the clinics. Another key was the collaboration with the Ohio Department of Medicaid. As an example, as part of the Aligned Diabetes QI project that we talked about earlier, providers had lots of feedback. In response to barriers to diabetes care that was voiced by providers and patients, the managed care plans added coverage for diabetes self-management, education, and support.
Wow.
In addition, 3 of the plans removed prior authorization requirements for continuous glucose monitors, and all plans aligned quantity limits on diabetes supplies and piloted home A1C testing. These managed care plan interventions enhance outcomes for Medicaid enrollees by making it easier to obtain and afford diabetes supplies and resources.
Yeah, such great examples of tangible impacts for patients. I mean, directly affecting their health, all stemming from this collaboration. Incredible accomplishments. And as our listeners know, the cardio funding through MedTap is coming to an end in June. But the work doesn't stop here. It doesn't stop now. How do you see this work continuing and continuing to be leveraged?
Well, I see this work continuing primarily through a recently funded Regional Quality Improvement Hub infrastructure. MedTap funding was provided to the schools of medicine in 2022 to develop these regional quality improvement hubs across the state of Ohio to improve the health of Medicaid enrollees, taking into account local context of where people live. These quality improvement efforts have already shown blood pressure and glycemic control improvements within different areas of the state.
Wow. Mike, anything else you see related to sustaining this work?
Oh, yes. Ohio Schools of Medicine and affiliated health systems, they have a very long history of working to improve the health of their communities. So they'll continue to incorporate the lessons learned that are related to capacity building and the networks that were established here. These can be used in future collaborative efforts to improve both workforce capacity and the health of the communities. In addition, Case Western Reserve University School of Medicine will sustain cardio.org, and the public can continue to access Cardio's extensive library of resources at no cost.
Glad to hear that. Cardio has really shown what's possible when we invest in primary care, when we share knowledge openly, and when we stay focused on improving care for the patients who need it most. So, to our listeners, thank you for being part of our journey. We encourage you to continue using and sharing these resources, which will remain available on cardio.org and on our web app. Please stay connected with your local and regional networks and carry this work forward in your own practices and communities. And looking ahead, stay tuned. The relationships and tools and infrastructure that's been built through Cardio will continue to support clinicians and patients across Ohio for years to come. We'll keep you apprised of any future developments and opportunities in the coming months. Shari, Mike, thank you for your leadership and for everything you've done to improve the health of Ohioans.
It was really a pleasure to talk about cardio with you on this final podcast. So thanks for having me.
Yeah, and thanks for having us. Cheers to 9 great years.
And a special thank you to you, our listeners, for tuning in to Cardio Radio.
This concludes today's podcast. Be sure to visit cardio.org to learn more about the Ohio Cardiovascular and Diabetes Health Collaborative.